I'm Dazon. Hey! And you're listening to Visible and Unseen, chronicling HIV in Black life, then, now, and next. We're amplifying stories and highlighting voices of Black folks in the movement. Some you know, and some you should know. Now let's jump in. Well, here we are. Welcome to Visible and Unseen, Dr. Keith Rawlings. So excited for this conversation. Are you?
I am glad to be here, Baton. Absolutely
Excellent.
looking forward to it.
Me too. Well, I'm going to dive right into these questions because I know this conversation is going to be all of that. So let's just start right out at the beginning. I'm going to start right at your beginning, Keith, and that
Okay.
is tell us, when did you meet your first patient living with HIV, and how did that impact the trajectory of your life, of your pathway?
Well, interestingly, when I met the very first person was, I believe, in 1984. And it was a young man who was admitted to the hospital with hemophilia and happened to have pneumonia. It turned out that he had what we now think of as pneumocystis pneumonia. He was a young man who came in and really did not seem to have very much in line of family support at that time. Um, I happened to be on call one evening and literally watched as the dietary staff would put his food on the floor outside of his isolation room because in 1984 they were very, very afraid of the idea of actually going near this person with this strange infection that we didn't quite know what it was. Long story short, after a couple of nights of noticing this was not my patient at the time. I put on a gown and hoodies and mask and shield and all the other things, and literally just took this guy his food because he was sick and he was trying to literally get cold food off of the floor. So I took it to him. The next day, I got pulled over by the chief resident, who pretty much asked me what was I doing and what was wrong with me. I was a little confused at the point, but he asked why would I do something like that to go into this guy's room and to take his food. My comment was simply that hospital food was not all that good to begin with, and cold food having to get off the floor seemed a little bit barbaric to me. Um, and after some back and forth about, you know, you're married, you have children, you have a child, what is wrong with you? I
Mhm.
couldn't give him more of an answer, so his answer to me was, well, I guess he will now be your patient.
Mm.
And literally, that is how I saw the very first person at that time. The irony of that is over the next about year and a half, um, while this young man was a white male with hemophilia, but also was a man who had sex with men, the next 9 patients that I saw were all black, and half of them were women. This is
Mm.
Baltimore in the 80s,
Mhm.
so
Mhm.
this did not comport with what we were being told, but it was clearly indicative of living in a city with a very large black population and a population that was also one that had a fair amount of injection drug use. And that literally took me down a trajectory that I did not think or did not anticipate until maybe about mm, about 6 months after this young man, I was listening to a lecture from the CDC who told me that this was infection that we would now didn't even call HIV in those days, that was likely to be impacting about 1 million people in the United States by the year 2000.
Mm.
And I realized because I was, was married, my daughter had been born, and I realized that given the risk factors and where we lived and all those kind of things, that if my child did half the things that I would have thought of in terms of being an active teenager, um, would have potentially put her at risk. And I realized not so much as a clinician, but as a father, that I needed to do something to be protecting of my own child, and if not mine, at least others that I knew. And that literally is what sort of has projected me down this path of HIV care and treatment and prevention and research and education for the last almost 40 years.
That's like a long trajectory of a lot of different parts of the response. So there's the
Okay.
care, and then there's the treatment, and then there's the research, and there's the policy and advocacy. And it seems what's driven, if I get it wrong, you will correct me, if it's driven by really a deep sense of altruism. It's sort of, and we don't necessarily think about clinicians in that way always, but it is. It's, I'm doing this not only for the good of my own family, but for others. And would you agree that that somewhat is what has driven this? Is that this is about a larger concern? There's an epidemic. We have to
Right.
deal with that.
Yep.
There's a health crisis. We have to deal with that. But it's such a larger context that we're talking about dealing with it in. And it's about quality of life for our people. I don't know. What do you think?
Well, I think that one of the other things that occurred in the early 80s for me was joining the Student National Medical Association, which is, for those who don't know, this is sort of the Black medical student organization that we get together and try to talk about things. But one of the policies and one of the philosophies of the organization literally was that healthcare is a right, not a privilege. And the concept of, for me, and why I ever went into medicine was to hopefully be of help and to provide care in the communities that I grew up in. And the idea that there is a large scale pandemic as it was growing and emerging that was killing people on a pretty consistent basis. I mean, the early 80s, mid 80s, even late 80s, HIV was pretty much considered to be a terminal disease that you were going to die of.
Mm-hmm.
And so this concept of being able to provide care in the community, whether or not that was my home where I grew up, or in my household, or in my neighborhood, or wherever I happen to be, is sort of what drove me and continues to drive me in many ways along the idea of not only how can you provide care, but how do you do it in an equitable way? What is
Mm-hmm.
it that people need in order to be able to address this? And it is not just providing medical care, or in those days, there were no treatments. This was
Mm-hmm.
mostly about compassion and how do you provide people with care in a way that is dignified and that is consistent with what you would hope that your healthcare provider would do. Um,
Mm-hmm.
the other thing that ultimately moved me very far along this is that the care was never equitable, that there were some people who got certain things, other people didn't. And that reality also kept me very much focused on the idea that making sure that if it was in the people who were coming to me for care or coming to me for questions would be able to get high quality care in a equitable and compassionate fashion
Mm-hmm.
as we were dealing with people who were dying, and then ultimately getting the state of the art care for people who were living, and then now even for people who may benefit from prevention that now is available.
I'm glad you said that, because my next question is, so equity has been a part of this the whole time, quite frankly, especially just in terms of identifying how and when and where um, Black community entered into this epidemic.
Sure.
But what do you fight for now that you didn't expect to fight for at this stage in the epidemic?
Well, I guess the easiest way of thinking about this is as we begin to develop therapies, whether or not
Mm-hmm.
those were the early antiretrovirals, treatment for opportunistic infections, the ability to better understand what was going on through testing and identification. I always thought that as the technology got better, that the accessibility and the access and the engagement would also follow along in the same way. And to be honest, it has improved dramatically. There's no question about that. Um,
Mm-hmm.
the majority of the people living with this diagnosis of HIV are in care. they are receiving care. They are getting care in a manner that would have been unheard of 3 decades ago,
Mm,
4 decades ago. But what is clearly, I think, the thing that I didn't believe I would have to keep fighting about and arguing for was the level of representation in our understanding of what was going on
mm,
in clinical research. The idea that the bulk of the epidemic in the United States is now amongst people of color, particularly Black people and um, Latinx. And yet, that is not reflected in the research, or often is not reflected in the research in comparable levels. And I think one of the things that has been, I guess, of great benefit or great improvement in this conversation is the admission by entities like the NIH that we have seen a failure of having adequate representation. And this
mhm,
idea that these things work exactly the same in everybody is in most ways true. There's very little biologic difference that goes on in relationship to HIV. But it is clear that the representation in how we think about it and how we manage it is not equitable. And I think that is the thing that surprises me and frustrates me, I would
mm,
add the most about how we have moved along this path. We have pretended for a number of years that this was not a disease in our communities. We
mm,
have been treated as though we were not part of the conversations in terms of which communities need to be engaged in the discussion, in the planning, in the promotion, and the adequacy and equity of funding.
mm,
But I think that the other thing that has really surprised me in a worldwide epidemic that is mostly Black, that is 50% at least female, how we continue to pretend or to devalue in certain ways the
mm.
presence and the life experiences of particularly Black women.
Yeah.
I think those things are the ones that um, representation in research, the inclusion and engagement of Black women, both globally but particularly in the United States, the reality of the geography of the disease that many of us have known now for 30 years, it is overwhelmingly in the South, and yet we still sometimes do not see the same level of resource allocations. Is that improving? Yes. Has it gotten better? Yes. Is it equitable? Hmm. That is the place where I think we really need to say giving everyone the same when certain groups have substantively more is not equitable. That may be equal, but it's not equitable. And we know where the need is and where it needs to be um, identified and applied. And that is the places that I think most um, still challenge me in 2023.
Right. Absolutely. Thank you for that. I think that what you're bringing up in terms of how this whole trajectory around equity has continued to play out is in some ways identified through some of these things called what I don't necessarily support in the framing of social determinants of health, because I think, determinants of inequity are clear. The social determinants of health are a little bit fuzzier because some of those things are fixed and some are political and some are, other
Sure.
than changeable through societal means. So if this issue of equity is going on to this point, what you raised, I want to come to in my next question is this whole idea of the fact that women, cisgender women in particular, before we even get to femme identified, gender expansive people like trans women, women are more than half of the epidemic in the world. That's not what it looks like in the US, but in the world.
Yes.
And by the experience of Black women in the US, we are a part of that uh, denominator, if you will, of Black women in the or that whatever the top one is, I'll come up with it. The denominator
Numerator.
is the bottom one.
Numerator.
The numerator. That
Yes.
Black women are the numerator. Um, why is it important? Why is it important to champion Black women's leadership in the HIV movement?
Well, I think it's important for lots of reasons. Very clearly, we live in a society where things are being done currently
Mm-hmm.
with regard to the healthcare of women and mostly being decided by men. And we have seen repeatedly that pretending that one group is going to be able to dictate what happens for everybody else in a way that may or may not be um, appropriate or equitable or representative just doesn't seem to work. Um, we have
Mm-hmm.
seen a lot of occasions where we have looked at, well, if it worked in men, we can apply it to women. That's not true.
Right.
The idea that the same needs, the same concerns, the same considerations apply by gender is frankly not borne out in almost any aspect of healthcare. And
Mm-hmm.
particularly when you overlay the idea of inequities that are not just by gender, but also by race. We live in a society that is amazingly and overtly been focused on differences and disparities for race since its inception. And to pretend that it's not true in the medical community is just not a very good read of history. And it is clearly not a good read of what is currently going on in healthcare. There is virtually no disease state in which we are not seeing a greater degree of burden or a lower degree of the appropriate outcomes by race in this country. And that
Mm-hmm.
is a unfortunate but a consistent part of our history that we often like to pretend as every new thing comes along. Well, no, that's not really true. It is true. It has been true. It has been repeated over and over and over again. And as you know, I don't know if this really truly is Albert Einstein, but doing the same thing over and over again and pretending you're going to get a different result is the definition of insanity, or
Mm-hmm.
it is the definition of outright bias. So I think that both of those things are in place. But in order to do this, and I think this is particularly true in the African American community, is that in healthcare and in my experience, it is the women in our community who drive this conversation for both themselves, often at at the expense of themselves for others in the family. But it is the women who have been the primary encourager, provocateur, or frankly would be the simply drag my male clients often into get care, or it would be the ones who would s- sacrifice their own issues in order to make sure for their children. I think this is a reality that we miss when we pretend that if you just talk to that guy, that is sufficient in order to get anything done. The
Right.
other thing, which is basically an observation that I've made years ago, it's not just that you have to get people to physically be involved, but it's also about the validation in the community.
Mm-hmm.
If I go in and have a conversation with my client, that's great. But I guarantee you that if that person does not hear similar kinds of things coming from others that they trust in the community, who are often the women in the community,
That's
then
right.
it does not work as well. And so I think that combination, particularly as you look at communities of color, have to be considered and taken into account. And they need to be included not just in how do we fix it halfway through, but in the design, in the, are we asking the right questions? Those are
Mm-hmm.
things that are ultimately, I think, require leadership and definitely inclusion of women in the context of these conversations about treatment, about prevention, and I would argue also about clinical research.
So,
Yeah.
who are you passing the baton to next?
Well, I think that there are lots of different ways of passing this baton.
Yeah.
The one that I have been focusing on a lot of late is how do we begin to change the representation in terms of who is actually conducting and engaging in the science,
Mm-hmm.
um, particularly around clinical research. If we don't start to invest and to focus in on that, then when people like me and stop doing this, which is the inevitability of time and age and health and all those other kind of things, um, there will be others there, but if we don't start to give them the same resources, then they're starting at an even further deficit. And so I
Mm-hmm.
think that it is important for us to make sure that we're getting more of our community into medical schools. into schools of nursing and schools of public health and schools of pharmacy, that we continue to support and encourage that. There are lots of residency programs that are not even filling all of their applicants in terms
Mm,
of being able to fill their slots because there's just a shortage of this population.
mm,
The other group, though, that I think is important is to make sure that we are actively encouraging and in many ways doing something that I did not see a lot of in my career moving forward, which is active mentorship of people that look like you.
mm,
Um,
mm.
the idea that, you know, this is a hard enough thing to do to make it from day to day in life. The idea of trying to traverse some of these systems when you don't understand the pitfalls or some of the, the potholes that can be in your way or obstacles is important for there to be mentorship. And I think it is something that we don't actively do as
Mhm.
well as we should, not based on race or geography, but the fact that there are not enough of us to take care of the populations that we are now seeing. This is not only true for HIV. We need people in every aspect of healthcare.
Yeah.
And there's a fair amount of data that says that there are different outcomes if you have a discordance of the person who you are seeing. If this person is not familiar with you
Mhm.
culturally or from a gender perspective or a historic perspective that you feel comfortable with, we see that there are clear evidence around this level of discordance. And if we want to change that in the community, those of us who have been here for a little while and doing these kind of things have to bring more people on behind us in that context.
Thank you. You are actively mentoring. I have just been mentored. I am receiving all of it as this individual, in addition to everyone else who is enjoying this conversation with us. I am sufficiently noted and
Good.
notified of what you said, and
Yeah.
I'm learning that because I am a house of ideas all the
Hmm.
time, and I write them down and now I share them. And
Yes.
if people want to pick them up and run with them, great, because ain't no way I'm trying to manage a run with them anyway. So
Right.
I feel you, and I'm so, so, so grateful to you for this. Look, so whether you think you're actively mentoring or not, you are. I've been told that I'm a secret mentor, that I didn't know that I was mentoring, and
Yeah.
I was. And so you too are a secret mentor. You're mentoring many, many, many that you don't even know, and probably over years and years, and you may never know. So I'm going to just do a collective much appreciative love to you for that. On behalf
Thank
of
you.
all of those who have been secretly mentored by you. Dr. Keith Rawlings, thank you, thank you, thank you so very much, not only for this conversation today, but just for you, for doing, being, giving, and contributing to this work, for saving hundreds, if not thousands and thousands and thousands of lives, and continuing to save millions of lives. And I'm not exaggerating or hyperbolic when I say that, because I know what
Yeah.
you do. And the fact that what you do actually does touch and save millions of lives matters so much. So much appreciative love to you, Keith. Thank you.
Thank you. Jason, thank you very much as always. It's always a pleasure to talk with you. The last thing I will say is that it is incumbent upon all of us to step into the breach,
Mm.
take up arms to battle against whatever it is we're going to be fighting against. And trust me, there are more than enough things for all of us to participate with. If this is not your issue, I'm sure there's another one. And
Hello.
all of them are impacting our communities in ways that they need your help and support. So for you, sister, absolutely continue to do the work that you're doing, and hopefully we'll be able to eventually have a dent into these issues.
Ashe.
Ashe.
Thank you for listening to Visible and Unseen. I'm your host, Dazon, and I'm also the founder and president of Sister Love Incorporated. To find out more about this podcast and the work we do at Sister Love, visit us online, www.sisterlove.org, or follow us on Instagram at Sister Love Inc. And tune in next time for another episode of Visible and Unseen. And much appreciate love.